Sorry, everyone who's watching online. That's the first time this had happened, so there's a first time for everything. Okay, well, you can go back and maybe watch the recording, I don't know. Okay, so let me relist these people because this is important. These are the people on the Centennial Committee. It was chaired by Cobbs Nixon, included Angela Chang, Jeff Aslan, Cameron Nixon, who is joining us virtually, Tom Robertson, who came in, Pat Tant, Zadok Williams, Bill Canto, who is sitting with Cobbs over there, Larry DeMyers, and then two members who are no longer with us, Tom Robertson and Sam Tyson. This committee worked tirelessly on multiple fronts to recognize our club's centennial year, and I just wanted to acknowledge that work publicly and let them all know how much we appreciated everything they did. Last spring, the committee worked hard on a centennial gala to be held in May 2021 at Augusta University. And then, as you know, COVID-19 shut down all plans for large gatherings, including our gala. The committee was also working on erecting a marker down at St. Paul's to commemorate the club's rich traditions and contributions to the community. And the board of directors is still currently working on how we can make that happen financially. The final component of the centennial celebration was to make a large philanthropic gift to Augusta University and the Children's Hospital of Georgia. We are now finally able to begin the process of making that gift. The original plan was to make a lump sum gift of $100,000 to the Children's Hospital of Georgia, but various financial realities, including restrictions on our scholarship endowment, made such a donation problematic. After much creative planning and negotiation, aided in large part by the hard work of our member, Nick Uros, who is also our welcoming committee today, the board of directors voted to give a gift of $50,000 to the Children's Hospital of Georgia over the next decade by allotting $5,000 of the funds we raised in our annual charitable trust campaign for this donation. Further, the trustees of the scholarship committee have agreed to award $5,000 in scholarships per year over the next decade to Augusta University students who are residents of the CSRA and pursuing degrees that will benefit the health needs of children. Combining the $50,000 direct gift to the Children's Hospital of Augusta with the $50,000 in scholarships to be awarded to Augusta University students, we are able to honor our commitment and make this significant donation to Augusta University and the Children's Hospital of Georgia. I always want to say it's Georgia, CHOG. So today I'm honored to present Debbie Vaughn from the AU Foundation with our first $5,000 gift to CHOG. And Lowell has our big check. We also have a real check to give you. Okay, I'm gonna come over. I'll be right back, people online, now that I'm unmuted. We're gonna take a picture.
Don't say G, say CHOG.
Say CHOG. Okay, sorry about having to leave the screen for that. So Debbie, we want to thank you for working with us and your patience over the past year. We have become good friends via the phone, and it was great to meet you today in person, and we appreciate all of your help in working through the ins and outs of this gift. Once again, I want to thank everyone who made this gift possible, the Centennial Committee, the scholarship trustees, the board of directors of the club, and most importantly, each of you who donated to our charitable trust over the years. It's an honor to be a part of a club that does such wonderful things. Okay, so in lieu, Lowell, you're promoting our the deplorables. For those of you joining us online, we have a new deplorables table in the back, and they're acting like the deplorables table. Okay, so in lieu of a history moment, I have decided to switch to acknowledging the national day that we were supposed to celebrate today. So in case you're unaware, June 7th is National Chocolate Ice Cream Day. Here's a little known chocolatey morsel of info for your National Chocolate Ice Cream Day celebration. Chocolate ice cream was actually invented before vanilla. You heard that right. The earliest ice cream flavors were actually modeled after drinks. So chocolate naturally came before vanilla because hot chocolate was very popular in the 17th century in Europe. In fact, the first frozen chocolate recipe was published in 1692 Naples in the book, The Modern Steward, and much later chocolate ice cream found its way to the United States. Another fun fact, did you know ice cream sundaes were actually made to be served on Sunday? Ice cream was a popular addition to soda drinks in the local soda shop, but by laws on Sundays, this drink was not allowed to be sold. As a way around this, the popular ice cream parlors chose to serve ice cream with syrup without soda to get around the laws. So they were able to have these sugary treats on the Sabbath, or so the story goes anyway. So don't forget to celebrate National Chocolate Ice Cream today. So now we are going to do our attendance prize. As a reminder, we're doing gift cards instead of our traditional bottle of wine. I have the attendance slips for everyone, and we're going to ask our speaker to choose one of our attendance slips here. The winner is Derek May, who wrote, quote unquote, the winner on his ticket. You get a $20 gift card to Subway provided by Dalton Brannon, so you get another meal out of this meal. Apparently the key is to write the winner on your ticket. Okay, so now we are going to move to our program, and I'm going to share the screen here. So at this point, I'm going to ask our President-elect Troy Lanier to come up and introduce our speaker.
In this time of the pandemic, we're making a lot of progress toward moving past it, but we have someone here today who can give us a lot of information and hopefully paint a rosy picture of the future for us. Dr. Philip Coule is Vice President and Chief Medical Officer of Augusta University Health System. He also serves as Associate Dean of Clinical Affairs of the Medical College of Georgia. Gained his medical degree from MCG in 1996 and received his MBA from Tennessee in 2012. He is an expert in emergency medicine, disaster preparedness, and mass casualty triage. He serves on the board of directors for the National Disaster Life Support Foundation. And he also serves on the board of directors for the Georgia Regional Academic Community Health Information Exchange. And that's an electronic platform that promotes care coordination and quality through an efficient, meaningful healthcare information network. And Dr. Coule is going to speak to us today on the vaccines that people have been taking and give us more information about those vaccines and what the future may hold for that. So please give a warm, Kiwanis welcome to Dr. Philip Coule.
Thank you. It's a pleasure to be here, and thank you for the warm welcome, the food, and also the nice donation for the Children's Hospital of Georgia. That is fantastic that you guys are giving back to the community. Remember that you have to honor the deal. I get half of that, so it's only $10 to Subway. I get the other 10, right? Okay. All right. I am just going to talk to you a little bit about COVID-19. I am going to talk a lot about vaccination, and I know that probably a large number of people in this room have been vaccinated, but I want to make sure that I help to combat some of the misinformation that is out there. One, about COVID-19 in general, about the vaccine. Some of the misinformation has been nothing short of just jaw-dropping that people would spread such misinformation. And the conspiracy theories and even the foreign government-sponsored campaigns to undermine the confidence in the vaccine has been pretty remarkable, and I'm surprised it's not gotten a little more play in the public. But if you have questions, feel free to raise your hand. I would much rather talk about questions that are on your mind, questions that you have. If I can answer it, I will. If I don't know, I'll give you my best opinion about whatever it is. But if I don't know at all, I'll tell you I don't know. But anyway, let's get started. So I'll just talk a little bit about COVID-19, a little bit about how COVID-19 vaccines work, why to get vaccinated, some common myths and misinformation that is out there, and then give you a little bit of a forecast of kind of where I see things going next. As I refer to it when I'm talking to my leadership team at the university or at the hospital, I call it reading the tea leaves. Some of this we've been able to predict fairly well based on previous pandemics, what we're seeing in the data and the early data, and been able to kind of forecast where we're going next pretty well, and we'll hope that holds true moving forward. So I apologize that some of the slide is covered up here on the screen, but a couple of important things to know about coronavirus. So remember, prior to this pandemic causing an outbreak, if you weren't in healthcare, you didn't even know what a coronavirus was. If you weren't a physician or a nurse, probably never heard of a coronavirus. Coronaviruses are a common virus. There were 4 existing viruses that infected humans, actually 6 prior to this particular outbreak. This became the 7th one. They're associated with a common cold, and the 4 common coronaviruses prior to the last 3 that have caused some pandemics were responsible for causing about 15 to 30% of common colds. So if you had a common cold, 15 to 30% chance it was caused by a coronavirus, particularly if it was a bad cold. The coronaviruses are named for the crown-like spikes that come out of the virus itself. When you look at it under an electron microscope, it also looks kind of like a picture of the sun, if you've ever seen that, with the corona around it. That's where the name comes from. They were first isolated in 1937 from an infected bird, and the first human coronaviruses were identified in the 1960s. A total now, including the current outbreak, of 7 coronaviruses. And it's important to understand that the immunity to coronaviruses is complex. The previous thinking prior to this pandemic, and still appears to be the case, is that immunity to one main type of coronavirus does not confer immunity to another type of coronavirus. And how you develop that immunity and what component of the virus you develop the immunity to kind of matters in terms of what happens with previous, or with other types of infections. A very important concept to understand is that a positive test does not equal COVID. A positive test is a positive test. Not all tests are created equal. Not all PCR tests are created equal. PCR is polymerase chain reaction test. We've got a lot of tests out there that will give a false positive, and false positives are also positive with the test. Not only that, a true positive, meaning that the test is positive, does not mean that the person will go on to develop disease. We know that there are people that get exposed to the virus, clear it, and never go on to develop disease. Now, why do I make a big deal about that? There are people that have gotten a positive test, maybe didn't feel well, but didn't get real sick. And those people may not have developed long-lasting immunity. So in other words, if they kind of handled it early on, or their nasal passages were not particularly hospitable to the virus, you didn't get a big dose of it, you can have a positive test, maybe some mild symptoms, but may not have long-lasting immunity. And that's one of the reasons that it's important to get vaccinated. When we look at previous outbreaks of coronaviruses that have been of major concern, so coronaviruses have been a problem in nursing homes for years. Every winter we would have outbreaks of coronaviruses in nursing homes. that would result in significant morbidity and mortality, cause a number of deaths in nursing homes. Respiratory illness in the winter in a nursing home is almost always coronavirus that causes this. Other bacterial infections, of course, do occur as well. But there have been three coronavirus outbreaks. And the reason that this is important is because when we talk about what we know about coronaviruses and the development of the vaccine, this history is incredibly important. So the first coronavirus outbreak that we had was called SARS-1. We just called it SARS, severe acute respiratory syndrome from coronavirus, or SARS-CoV. I put the one on for emphasis. That was in 2002 to 2004. Never really impacted the United States much, except in Detroit. Detroit had some outbreaks of this. Impacted Canada a fair amount. The large majority of these were within the confines of China, and it didn't cause a worldwide outbreak otherwise. You see the mortality from that, only 774. As quickly as it began, it just disappeared. Then we had MERS, or Middle Eastern Respiratory Syndrome. MERS-CoV was the next coronavirus to come onto the world picture, and that was 2012. We still occasionally see cases cropping up in the Middle East. The camel is the vector for this disease. Again, only 858 cases as of the time this slide was made, which was in February of 2020. And then, of course, we have the current outbreak that we say started December. It clearly started before that. We've documented that at least in October, we had cases occurring in the United States and didn't know it. So that, of course, is the current ongoing outbreak. Now, why is that important? Because when you look at vaccine development timelines, people will say, oh, this vaccine was rushed. We got there too fast. It's not possible. So then they cook all of that into a conspiracy theory about how we got to where we are, that we somehow developed the vaccine while this disease was being created and then had it sitting in the ready. The reality is that the research into a vaccine for coronaviruses ramped up back in the first SARS, or SARS-CoV-1. A lot of research started going on then. This is also the source of much misinformation, because people will find a journal article that was written in 2003 and say, see, this disease is not new. And of course it says severe acute respiratory syndrome coronavirus, or SARS-CoV, but it's SARS-CoV-1, and they don't understand that this is a different disease. Same family of viruses, not the same thing, but this causes a lot of confusion, fuels a lot of conspiracy theories. But it's important to understand that the research into vaccines started way back then. Additionally, when we had the Middle Eastern Respiratory Syndrome outbreak occurring in 2012, that really spurred on a lot of research into how we create a vaccine for coronaviruses. So when this pandemic started, we weren't starting from a position of this is something new. We were starting from a position of this is something new that we already know a lot about. Additionally, a lot of research had been going on concerning how to make vaccines for other viruses, notably Zika. And in fact, when Zika hit the world stage and started causing all of the birth defects in South America, the pharmaceutical companies had actually perfected toward the later stages of Zika a vaccine delivery method using messenger RNA and had trialed it successfully. But then Zika just disappeared. So this is all the framework for how we kind of got to a vaccine as quickly as we did, is that there was a lot of research going on in multiple different areas. But we also talk about vaccine timeline developments. Vaccines and their development, when people go, well, it took 50 years to develop a vaccine for polio. Well, true, that is true, but information didn't fly around the world in seconds the way it does now. And we also could not leverage research that's done in England one day and published the next day, and we're reading it in the United States the very next day. So when the world kind of became focused on this, there were a lot of things that got accelerated. And in anticipation of this, the federal government had developed these emergency use authorizations and streamlined a process for fast tracking an approval process that didn't eliminate any steps. It just cut out all of the bureaucracy and red tape in between. For example, normally one would conduct a study, you would compile all the data, you'd submit it to the federal government where it would sit for some period of time before somebody finally decided to review it. And then they conveniently hold a meeting months later, and then they review the data and they say, well, let's talk about it at the next meeting. And then they talk about that months later. And then they would finally send back and say, we need more information. And instead, what we had was contemporaneous review of the data, still independently monitored, but all occurring simultaneous with the research that was occurring, so that when the data was compiled, it was immediately submitted, reviewed, and approved for the next step. So a lot of bureaucracy cut out and things happened simultaneously in order to speed up vaccine development. Now, when we talk about vaccines, you have to understand the structure of the virus. The virus has an envelope or an outer coating that has these spikes coming out of it, which is where the name comes from. This is, graphically represented on the picture on the bottom right of the screen. I point out this picture because this picture is the image seen around the world, was drawn by a graduate of where? Augusta University. And this has been one of the most viewed images over the world over the past couple of years, and it was drawn by a graduate that learned medical illustration right here and went to work for the CDC. But those red spikes on that drawing are actually represented in the top right of this, and it's somewhat covered up, but basically that's the spike that's coming out. This is the area that the vaccine focuses on. Now, the envelope is necessary in order for the virus to infect someone. It attaches to a particular receptor using that spike. And if you develop antibodies to the spike, it actually will destroy the outer coating of the virus. It destroys its ability to infect anyone, and that results in the virus being harmless at that point. The vaccine that we give you actually causes your body to make just that spike. No virus itself, but just the spike. And that's how the vaccine works. And we'll kind of talk about that. So basically what happens is you get injected. The vaccine consists of just what's called messenger RNA. Messenger RNA is then that for that spike, for instructions on how to make that spike by the body, is frozen in fat globules. Basically, they just encase it in fat globules because your body will destroy it very quickly. And that is injected into the muscle. Your cells take that up, and what are called ribosomes in the body are these little mechanisms that sit out in the cell of the body. Basically, all ribosomes do is take a set of instructions and make proteins. That's all they do. So whatever instructions you give them, that it just cranks out whatever that protein is. So the vaccine actually consists of a little messenger RNA that says, make this protein. So the ribosomes get that. So when it takes in the vaccine, it goes to the ribosomes. Ribosomes take those instructions and says, okay, make this protein. So it starts cranking out this particular protein, and this protein is actually the same. It is the exact same structure as the spike on the virus. So it kicks those out of the cell, and when it does, this gets out into the bloodstream, and other cells, your body's white blood cells of various types, basically see this protein out there and go, that looks like something that doesn't belong. So it takes it in and says, oh, this is an infection, I need to fight this. And that causes your body to then develop these antibodies depicted by these little Y-shaped figures down here on the bottom to that particular spike. Now, once the ribosomes make this protein, think of it like just shredding that information afterwards. So it makes that protein, and then your body's normal mechanisms that destroy messenger RNA just cut it up and it goes away. It disappears. It doesn't enter the nucleus. It doesn't change your DNA. It doesn't change any of your cell structures. It simply just uses those instructions, says make the protein, then it goes away. And what your body made of these little proteins then stimulate the immune system. And when it stimulates the immune system, you develop some memory, some what's called memory T cells, and then you manufacture these antibodies that are then circulating out in the body. Now what happens is, so now that it's made these antibodies, now you get a real exposure. So the real virus shows up and the body immediately goes, oh, I've seen this before, pulls out the ability to make those antibodies and says, make these antibodies again, and you destroy the virus without ever developing the disease. So both the Pfizer and the Moderna vaccine use this technique, and these are the ones that are most effective. The Johnson & Johnson or Janssen vaccine, as well as AstraZeneca, as well as many others that are in use in other countries, use a different mechanism of what's called a non-replicating viral vector. We're not going to talk about that. That's a little more consistent with how other vaccines are made. But both of these vaccines are, again, work very similarly. And it's a 2-dose system. Why is it 2 doses? Basically, it's called a prime and a boost. So the first dose kind of trains you up to do this. Second dose really ramps it up so that you develop high levels of antibodies against the virus. Now, the Pfizer vaccine, of course, is 21 days apart. The Moderna vaccine is 28 days apart. Anybody know why 21 days and 28 days? Anybody know? But one's 3 weeks and one's 4 weeks. Literally, when they were designing the study, they literally looked on a calendar and went, okay, well, we need a little bit of time, so let's do 3 weeks between doses, and we'll do 4 weeks between doses. Those were 2 different groups. They used 2 different times. The reality is you could probably do Moderna at 21 days, or you could do Pfizer at 28, it doesn't matter. But those are the dates that were chosen for the initial trials, and guess what? We proved that they work, and so that's what we use. And until somebody proves a different schedule works, that's the schedule that we use. And why does that matter? It's people go, well, what if you miss a dose? What if you're late to a dose? The reality is it works just fine, and we've proven it works fine even up to 42 days after the infection. But it's because those were convenient blocks of weeks on the calendar to space out doses. The Johnson & Johnson vaccine is authorized under emergency use authorization. I didn't update the slide. It's not currently on pause anymore. It does cause a rare phenomenon called cerebrovenous thrombosis that appears to occur most commonly in women under the age of 50. And it's, again, a fairly rare side effect of it that does occur. It has been shown to occur with both the J&J vaccine as well as AstraZeneca. It occurs at a rate of about 0.87 per million doses of vaccine, which is still incredibly low. It is a fairly serious complication. The efficacy of the Johnson & Johnson vaccine is lower. Personally, we have more effective vaccines with a better safety profile in Pfizer and Moderna than we do in J&J. But for some situations, J&J is a better option. Talking about side effects from the Pfizer vaccine, this is Pfizer data. Pain at the site is the most common side effect. Fatigue, headache, myalgias, and chills. Now, it's important to understand, people go, well, why, does this give me COVID? No, this doesn't give you COVID. It causes your body to react as though it has COVID. And because of that, these are the symptoms that you get from your immune response to COVID. So think of this as just the side effect of your body's immune response responding to that. Very low rate of allergic reactions, but they do occur a little more commonly in the Pfizer vaccine. And that's because of that fat globule coating around the outside. Some people are allergic to that. Again, very, very, very safe side effect profile. Some common myths. One, the vaccine is experimental and it's rushed to production. People love to say, oh, the vaccine's not FDA approved. Okay, technically correct. It is authorized for use under emergency use authorization. But let me point out that none of the drugs that we use to treat COVID are FDA approved either. So we often use drugs off-label that are not FDA approved. So although technically that may be a technically correct statement, it is a misrepresentation. The vaccines are authorized for use under emergency use authorization. These vaccines built on decades of development that were used for other viruses and other coronaviruses. We didn't suddenly develop these overnight. A lot of work went into these. There is a myth circulating that the vaccines contain fetal parts. This is not true. There are no fetal cell lines even involved in the development or research of either the of either the Pfizer or the Moderna vaccines. J&J does make use of a line of fetal stem cells that were harvested from a fetus aborted. One of the cell lines was in the 1970s, the other was in the early 80s. But there are cell lines that are used in research that were harvested from aborted fetuses, but those cell lines have been cultured and continued over years. It's not used in production at all. That was solely in the research that was used for the J&J vaccine. Neither Pfizer nor Moderna makes use of any research using fetal stem cells. There is a common myth that because it has messenger RNA in the type of vaccine that it'll change your DNA. That's not true. It never enters the nucleus of the cell. There's a myth out there that it'll affect your fertility. This is completely unfounded. No major medical society, the reproductive health organizations, the American College of Obstetricians and Gynecologists have said this is completely unfounded. There's no evidence, there's no research, and no reason to believe that this would in any way affect fertility. And in fact, many pregnancies occurred during the phase 3 trials, even though pregnancy was an exclusion criteria and people were told not to get pregnant. There were pregnancies reported, and in fact, after the vaccination was began, we've already logged, I'm sure by now it's well over 100,000 pregnancies that have occurred in vaccinated women. I would argue that there's more evidence to support that vaccination causes fertility than it does to do anything to impair it, and that the vaccine contains a microchip. If it does, I'm not getting very good reception. I have tried the 10 hat routine to try to get better reception. I hear you're supposed to get 5G. I haven't gotten it yet with mine. There's no microchip in there. You can't get COVID from the vaccine. One of the common ones I hear is that I'm better off getting the disease naturally. That is false. This is one of the rare circumstances where the immunity from vaccination is more reliable and stronger than you do from the disease itself. Now, that's part of the reason that I mentioned earlier that the immunity is complex. For people that get mild disease, they may not develop good levels of antibodies, and therefore you don't have good, reliable protection in all cases, just because you either got a positive test or even had the disease. And so for that reason, getting vaccinated is actually recommended even if you've had COVID. There's also an interesting phenomenon with COVID long haulers. I don't know if you've heard about this or not, but people that get COVID and then have long lasting symptoms, particularly fatigue, occurring for just extended periods of time. A remarkable number of those people will actually improve if they get vaccinated. And it actually makes the symptoms better. So getting the disease causes long-term side effects. We know that it causes a phenomenon called the COVID fog, which is where people say they just can't think straight after getting COVID. We know that it has cardiac side effects. Again, so it is better to get vaccinated than to get the disease. The variant that we're seeing locally right now is called the B117 variant. Last check, about 80% of all the cases in Georgia are due to the B117 variant, which is commonly called the UK variant. But the data about protection from the vaccines that are out there suggests that it is highly effective against the B117 variant, which is the UK variant, the South African variant, which is the B1351 variant, and then also the B16172 variant, which is the Indian variant, which is said to have the kind of double mutation. They have talked about tweaking the vaccines. The nice thing about this technology is they can slightly modify the messenger RNA for what it's encoding for and put that into a booster shot if we get a variant that escapes the vaccine. But thus far, all of the variants that are out there are well covered by the vaccine. We got a lot of people vaccinated now. I know we're running out of time, but the number of people vaccinated are what's protecting us right now from having major outbreaks, because people that are unvaccinated, if they haven't developed immunity, are really the ones that put us at risk. The chart's looking pretty good in that we continue to decline. This is a picture of the US, and you'll see that we have really just continued on a slightly downward trend, and that's what we've seen locally as well. One last slide. Is it reasonable to, this is my where are we going next kind of slide. Is it reasonable to meet in person again? Yes. If you're vaccinated, yes. If you're unvaccinated, probably shouldn't. But of course, if you're not vaccinated at this point, then you probably have some reason where you've chosen not to get vaccinated. I don't think there's any convincing you to do so at this point, perhaps. Is it reasonable to relax social distancing and not stay 6 feet apart and wear a mask? Yes, absolutely. Is it reasonable to resume domestic travel? Yes, if you're vaccinated. What about international travel? Yes. In fact, I just got back from Belize. It was spectacular. I highly recommend it. Recommend getting back out there. Is it reasonable to stop wearing masks? Yes. Can we eliminate some of these infection control measures? Most of these had no impact on COVID transmission in the first place. My favorite is every other urinal, bagged and covered up. I'm like, why? I'm not sure there's any data about transmission from urinals from one side to the other. At least I hope there isn't. Doesn't really make sense to me in the first place. I was just at the airport the other day and they still had the water fountain covered up with a bag. That makes no sense whatsoever. The data is that, and part of the reason for this is confusion over surface transmission. We originally thought that surface transmission might be a big vector. It certainly is a vector. So touching surfaces and then someone else touching the surface, and then, for example, touching their eye or their mouth or their nose. Is that around? Yes. Is it a major form of transmission of COVID? No. It doesn't appear to be the major form of transmission. And again, cleaning that surface or using hand sanitizer or something like that is perfectly reasonable as a way of controlling that. But we kind of got to start undoing some of the stuff that we did. A lot of the confusion around that resulted off of testing, for example, on a cruise ship, where they were documenting these extended periods of time that they could get the virus, they could isolate the virus off the surface on the cruise ship. The problem is they were doing PCR on that, which is picking up on the RNA of the virus, not infectious virus. So the RNA of the virus itself is not enough to infect anyone. You have to have the capsule, and the capsule is easily destroyed. So that's part of the reason for the confusion around that issue. But again, good cleaning of surfaces will certainly take care of that. Normalization of COVID vaccine. So where do we go next? We have to get COVID vaccinations just into normal routine healthcare. We've got to get COVID care into routine healthcare now. The healthcare system is getting back to normal. For example, today we have one COVID patient on a ventilator. We've got a couple of COVID patients on the ward in the hospital. People are still dying from this. I think we had someone die over the weekend from it, but it's not in the sheer numbers. For example, in comparison, at the peak of the pandemic, we had 145 patients in our hospital, of which about 90 were in the ICU. So really sick patients during the peak of this, but we're not seeing that anymore. And then we need to take a long, hard look at this pandemic and how it was handled and maybe how to do this differently next time. There were a lot of cracks in the healthcare system and in the infrastructure, the public health infrastructure. The strategic national stockpile, for example, was completely useless in this pandemic. And just as one example, there's a pipette that we use in one of our lab machines that we do a large number of tests on. For example, that particular machine can run about 2,000 tests a day. It's our workhorse machine. But for every test that it uses one of these little plastic pipettes that are manufactured where? In China. And guess what? Everybody in the world was fighting for these little pipettes. Request a local EMA, state EMA, federal EMA. So the US government could not procure these little pipettes for us when we were running out of them. But I was able to get them on eBay from a company that buys them up from labs that are closing down. That shouldn't happen. So request through the normal systems, no, couldn't get it. But if I put $40,000 on my personal credit card, I could get it off of eBay, and it's signed, sealed, delivered, the real deal, yet the federal government could not purchase it. So we got to take a long, hard look at what went wrong and how we managed this and really shore up the healthcare system moving forward. So with that, I will be glad to take any questions that you may have. Yes, sir.
There are some, I know you mentioned some of the myths, but there are some myths that we have been experiencing. And two of them is superstition and religion. And have you encountered that, what have you been able to say to those who are dealing with that, those factors as I have? And also, if it's possible to get this presentation today to deliver something we can do.
Sure, definitely willing to share, always glad to share. And have I heard that? Yes. I've had people tell me that they couldn't get the vaccine because, and the one interesting thing, the most common theme we hear about vaccine hesitancy, whether it is this group, that group, or I mean, and you can break people up into different communities and say why for that group, but they all have a common theme. Anybody want to know what the one unifying theme is when you put it all together? Trust of government. Is mistrust of the government is the unifying theme across all of them. Is I don't trust the government because I'm an illegal immigrant and I don't want to trust you with my information because the government's going to come after me. Therefore, I won't register to get vaccinated because I'm an illegal immigrant because I don't trust the government. Or I'm a legal immigrant, but I immigrated from Cuba where you didn't trust the government, and therefore I'm not going to get vaccinated because I don't trust the government. Or if it's particularly rural Georgia, and it's a mistrust of the government and thinking that this is all a conspiracy, or if it's communities that have had a lot of mistrust of healthcare and how government has overseen healthcare and experiments that were done on groups that shouldn't have been done. They all have the common theme of a mistrust of government, which is why I think it's important for healthcare providers to be delivering the message directly. Here's why I'm seeing this disease is real. The vaccine works and it is safe. And I have yet to admit the first patient to our hospital who's vaccinated. And that remains true today. And I have yet to see the first person to have a serious complication from a vaccine. That's absolutely true. So I think that's why we have to combat these things head on, and we just have to call them out when people say them. Yes.
We had one from the chat or the Zoom call. What about boosters? Do you think that we're going to need them, and when do you think? If so, when do you think?
So the question is, are we going to need boosters? And the answer is we don't know yet. I was reading some research that was just published that suggests that we may not need boosters unless we get a variant that appears to escape the immunity that we're currently getting from this. But right now, the data says that if you developed antibodies from the disease, documented antibodies, that you're probably good for at least a year. We think that people that have gotten vaccinated are good for at least a year. We don't yet know how much further that's going to go out and at what level people's immunity may drop off to make them susceptible to the disease. But there's two issues at play here. One is a level high enough to keep you from getting it at all. And the other question is, at what level is enough immunity to prevent you from getting serious disease, which is really what we're trying to prevent. So that is unclear. My best guess right now is it's not going to be yearly like it is with the flu, but we'll have to wait and see. Now, I think this is where we should be a little mistrusting of the pharmaceutical companies, right? Because if they tweak the virus and come out with a booster, we need to follow that data closely to make sure that this isn't being a profit-driven decision. So that's where I'll start to get skeptical is, wait just a minute. I'm not quite so sure I'm ready to jump on that. And I'll tell you, I'm just being completely honest. If you're 12 to 17 and you don't have a high-risk medical condition, I'm not sure risk benefit wise, even though the risk is very low, I'm not sure that we really ought to be vaccinating that group. I think probably so. I'm just not as convinced as others are on that issue. Yes, sir.
Is there a test for the immunity? So here now, you take a test and determine whether you still got it or what level?
Yeah, so that there is, the question is there a test for the immunity? Yes, we can measure the antibody levels. The problem is we don't have enough experience to know exactly what level to set the cutoff at. In other words, okay, I can get a number, but the problem is I don't yet know completely what that number means until I have people that I know I've measured at that level who then never develop the disease. So it's a bit of an unknown is why we don't have a benchmark there to go against, even though we can test for it. Yes, sir.
Do you have a sense about when the Moderna and Pfizer vaccine will be approved for general use, opposed to emergency use? A lot of folks use efficacy use, not had it, so I was just curious about that.
Yeah, the question is, do we know when it's going to be approved by the FDA versus under emergency use authorization? Because a lot of people are using that as the excuse. My best guess is it will be by late summer. It'll be late summer, early fall. The FDA will come out with an approval. I hope it's sooner rather than later. The data is there. There's no reason why it shouldn't be fully approved right now. I think they're trying to be very careful. The CDC and the FDA have, at times, because of the politics, I think they've been a little overly cautious because nobody wants to make a misstep because obviously if you do, you get hung for it. So I think they're just being overly cautious about it. But I would expect that it'll be by late summer, early fall. That's my best guess. Yes, sir.
How are some of the learnings from development of these vaccines being applied to other illnesses? Messenger RNA, what's next? It feels like we should be able to do a lot more than just here.
Yeah. The question is, how are the learnings from developing these vaccines and the messenger RNA platform being applied to other viruses? A lot of people are talking about that right now. So as I mentioned, a lot of the development was around other viruses. There's a lot of, they were exploring messenger RNA as a way of making a more effective flu vaccine. So talking about using this technique to make a better flu vaccine that doesn't have as many side effects, that gives better immunity. Because as you know, the flu vaccine sometimes is not quite as effective as we need it to be. So there's a lot of speculation, for example, about using this approach for developing a vaccine for HIV. A lot of promise with this particular platform, and I expect we'll see lots of vaccines coming online using this technology. Don't know yet. I haven't heard any announcements of any yet. One last question, or yeah?
What about vaccine cards for international travel? Are there any complications with international?
Yeah, any complications for international travel with vaccine cards? I will tell you, Belize readily accepts it. That's where it just came from. You show your vaccine card, you skip testing or anything else, go straight through. But getting back into the US, that doesn't work. You gotta have a negative test to get back into the US. I can go to Belize with a vaccine card. Now, the problem is people are selling them on the internet. We got people creating fake cards. It's a little bit of chaos that way, but I expect you'll see more countries just accepting a vaccine card as in lieu of testing.
Derek, you want to?
I just wanted to say just one thanks for this presentation and how fortunate we are here in Augusta to have AU Health in the middle of this. And thank you guys for everything you've done through this whole thing. This has been, I mean, unbelievable year for all of us. And thanks. I just want to say thank you.
Oh,
Proud I am to.
thank you for the kind words.
Thank you. Thank you. I agree with Derek. That was a wonderful presentation, informative. And we do have some Kiwanis Club pins for you as a token. You can write out some important medical things with that. Dan Rogers, you wanted to make an announcement?
So we set up the Sam Tyson Scholarship Fund for Eagle Scout. We've got 3 applications completed, a couple more working on them. So if you're an Eagle Scout, I'm going to have Martha send a note out. I want you to reach out to me, let me know if you want to be on the selection committee so we can review these applications and select our first Sam Tyson Scholarship Fund recipient. And that'll be happening in the next 4 or 5 weeks. So we'll be in touch. Thank you.
Okay, great. And thanks for those of you who are joining us online. That was about the Sam Tyson Scholarship. We already have some applications for it, and we need members who are Eagle Scouts to serve on the selection committee. So if you're an Eagle Scout, email me or Dan Rogers about that. Want to let everyone know that our next meeting will be June 21st. Our speaker will be Mr. Jim Davis, the president of University Hospital, and he will be talking to the club about the sale of University Hospital to Piedmont. Just as a reminder, we will continue to meet bi-weekly through September here in the Palmetto Room. Want to thank everyone for attending today. We have some people who, I think this is their first meeting back. And so it's really great to see you. I think I've mentioned I get excited when I see someone that's coming who hasn't been in a while or joining us online. For those of you who are here, make sure you're telling people that you're coming, that it's safe, that we're having a good time. Good food, help us get everyone back here. Reverend Fry Rumor used to be a member of the club, so we're always welcoming you back anytime you want to come. And to our other guests, thank you very much. Okay, so some closing thoughts. Another fun fact about Chocolate Ice Cream Day. Do you know how many licks it takes to consume a cone of ice cream? Lowell says 2, but researchers have discovered the magic number is 50. So you can get yourself a cone and test that out and see where you fall on that distribution from 2 to 50. Okay, and finally, a bad joke in honor of Jess Aslan, who is not here today. What is an electrician's favorite ice cream flavor? Chocolat. That one was really bad. You guys have to let Jeff know. Okay, thanks to everyone. Thanks again, Dr. Coule, and let's all have a wonderful week and see you back in 2 weeks.
Yeah.